Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Today, projections of excess deaths in Gaza. Paul Spiegel is the director of the Center for Humanitarian Health at the Johns Hopkins Bloomberg School of Public Health. Tak Igusa is a professor of civil and systems engineering at the Johns Hopkins Whiting School of Engineering. Working with colleagues at Johns Hopkins and the London School of Hygiene and Tropical Health, they developed a way to estimate the human costs of conflict in Gaza. They explain this work to Dr. Josh Sharfstein. Let's listen.
Dr. Paul Spiegel, Professor Tak Igusa, thank you so much for joining me today on Public Health on Call. I want to start with you, Dr. Spiegel. Can you explain what this project set out to do?
Thank you, Josh. The project, where we worked very closely with the London School of Hygiene and Tropical Medicine, and the aim was to establish the number of excess deaths in the future over the next 6 months within Gaza. And we did that by trying to look at 3 different scenarios, which would be overall the extremes. So one would be a ceasefire immediately as of February 7th for the next 6 months. The other would be the status quo. What would happen if, even though there are lots of ups and downs, what would happen if the current situation continued? And then finally, an escalation. What would happen if it got a lot worse?
And by what would happen, you mean really how many people would die?
Yes. Excess deaths, meaning specifically, these are the deaths that would occur if, because of a war, and if there was no war, these deaths would not occur.
Got it. I imagine that answering those questions requires putting together a model of the future.
Yes. And that's why we needed a very diverse team of humanitarians, people who understood the situation, but also people that can actually do modeling. And so these are projections, not predictions. We're not saying this is going to happen, but rather this could happen over a 6-month period. And so we used a lot of different colleagues and modelers to do this.
Now, Professor Igusa, I think you were one of those colleagues and modelers that jumped in to try to think through this question of how to project the number of deaths in a conflict under different scenarios.
That's right. So in my past work as a civil engineer, I used to do projections related to natural disasters such as earthquakes and floods. This is the first time I've worked in conflict, but many of the methods are the same.
Could you describe those methods? Keep in mind, I know very little about how to put together models like this.
Oh, yes, of course. So one thing is we need to rely on what happened in the past. So there is data from previous conflicts as well as data from Gaza itself. And we're able to use models from infectious diseases and also models of deaths due to conflict. And we put those together to really put a system of different models representing the different ways of mortality in the conflict.
And if I'm not mistaken, you were projecting not just the total number of excess deaths, but the number of excess deaths in different categories.
That is correct. And we had different specialists in our team working on each type of mortality.
Now, as a systems engineer, is your job to bring those together so that you have one group looking at infectious disease mortality, another looking at the mortality from trauma, and you're trying to put it together in one model so that it all coheres?
Yes, that's right. Right now, I was working mostly on the trauma part of the model, but in the next parts of in our future iterations of our model, we're going to put things together. So certainly things like food and water is going to influence infectious diseases and so on. So those are the parts of the system that we'll need to model to show how they interact and affect mortality.
One more question for you, Professor Igusa. You had to find a lot of data to be able to make assumptions for the model. How good is that data? In other words, how reliable is it in order to make sure that your projections are reliable?
Yeah, that was a very important question for us throughout our analysis. So fortunately, the Minister of Health in Gaza has been very careful with recording deaths and separating the ones where there's uncertainty. And so we use that data for one of our main sources of mortality. And then another source is from UNRWA, who is an independent source of data, and we tracked mortality there. And if we compare the two sources and did the math, they are consistent with each other.
Great. So, Dr. Spiegel, could you walk us through the findings of your projections?
Sure. What we did is as you mentioned, we have the overall excess number of deaths, and then we have by 4 different categories: those due to traumatic injuries, due to bombardment, for example, those due to infectious diseases, both epidemics and endemic diseases, those due to maternal and neonatal health, and then finally non-communicable diseases. But overall, in a ceasefire setting, so in this setting, it was a ceasefire where people would have access to medicines, goods, food, and water. There would still be in a 6-month period, including the epidemics, around 11,500 deaths, which is still a very, very large number of deaths. But then as we move forward and we go to the other extreme of an escalation, there could be upwards over a 6-month period of over 85,000 deaths.
And the status quo?
Status quo is, of course, in the middle of approximately 66,700 deaths. And each of these have a significant uncertainty level due to the assumptions that were made.
Let's take the ceasefire scenario where you're still talking about 11,000 deaths. What are you projecting that people will be dying from under that circumstance?
The primary disease would be infectious diseases, both endemic diseases, and it's primarily going to be acute respiratory tract infections, COVID, influenza, parainfluenza. But perhaps surprisingly to some, there still will be deaths due to trauma, even when the bullets and the bombs stop flying. And that's due to people who have had traumatic injuries, and they're still going to be dying due to infections or other areas where they're not able to get the medical care needed. And then finally, there would be a small amount of diseases that would still occur. People would die due to non-communicable diseases such as diabetes, renal failure, but also sadly pregnant and lactating women.
And those would be considered excess deaths because of the issues, the challenges receiving healthcare, even under a ceasefire?
Yes, because at this point, the healthcare system has been thoroughly degraded, and so it's not able to provide sufficient health care. Even if there was a ceasefire, that would still continue because given the what's been reported as famine-like conditions, there's going to be a tremendous amount of water and food that's going to be need to be brought in, medicines, and then the healthcare center is going to need to be very quickly rehabilitated. All of that's going to take time, and therefore there will continue to be excess deaths.
In a scenario of escalation on the other extreme, where are you projecting the deaths to come from?
Yes, perhaps not surprisingly, it would be traumatic deaths. And so when, as we mentioned in the extreme situation with epidemics, there'd be approximately over 85,000 deaths, but approximately 68,000 or so would actually be from trauma. And that's due to the continued escalation of bombardment, which are those immediate direct deaths, but also indirect deaths due to people that are seriously injured and then die, perhaps not immediately, but due to lack of medical care.
That is just devastating to contemplate. I would like to turn to the next phase of this project. Professor Igusa, you alluded earlier that your work is not yet complete. What is the next phase?
Well, the first report would focus mostly on the excess mortalities. And What we're looking at for our next reports, and we're anticipating 2 more reports in the next 4 months. What we're thinking of are other ways in which it's affecting the citizens of the Gaza Strip, including the disability, years living with disability. We're also looking to refine our methods, putting more of the systems perspectives to see how the various types of diseases and trauma are interacting.
Great. Dr. Spiegel, I want to ask you about your hope for how this data can be used. Where would you start?
Well, we are aware that the report has been shared widely with various governments who have been either involved in the conflict or have been involved in various talks and negotiations, as well as the United Nations. So while we don't know the effect of the report at this point, we're at least gratified that it has been shared widely. Our ultimate goal is to support, number one, humanitarians, so those who are actually responding in Gaza, to be able to better prepare according to different scenarios. Currently, everyone is working so hard on a day-to-day basis. Sometimes it's difficult for people to think ahead. And then lastly, related to various governments and other groups that are working to try to bring peace, hopefully this will allow them to be able to better understand the potential significance, particularly, of course, of the excess deaths during different scenarios. And hopefully that will allow them to better have a reality of what decisions and how the war moves forward, what the effects may be.
There's some people who might say that the number of casualties on any side of this conflict does not seem to be the driving factor in what happens next, in its resolution. What would you say to those people who say, well, it doesn't matter what a report like this might show because people won't take it into account?
Well, as public health professionals, we need to be able to provide particularly to decision makers and those that respond, the best evidence that we can and the best thinking and the best methods. And so we hope that will have an effect in terms of how people think. And if we look even at the various governments and their responses, I think we can see a change over time as the toll on civilians has really come to light on both sides. So we're hopeful that this report will have a very positive effect on those issues.
Well, Dr. Spiegel, Professor Igusa, thank you so much for explaining your work and look forward to its next iterations.
Yeah, thank you for having us.
Thank you.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Ceciri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Ceciri and Eliza Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.